Thank you, Mr. Chairman, and I apologize that I'm keeping you late, but I wanted to let you know how much I appreciated the panel that I was part of just a moment ago. I just ran in because I was told that you were holding things for me. But I was with our governor and had a chance to share some of the thoughts that we face on our health care costs, as you know, in our state. Very high, very challenging, and we have struggled to find some solutions. I want to ask a question that may seem to be a little bit parochial, but I've got such an extraordinary panel in front of me. I feel like if I don't take this opportunity, it would be lost. Back in 2004, Alaska put in place something that's called the 80th percentile rule. Any of you familiar with that? Okay, the 80th percentile rule sets a minimum for how much insurance companies have to pay when Alaskans with private insurance plans go visit doctors or other providers that are out of network. And so what the rule does is it requires the insurers to base their payments for out-of-network claims on the amount at or above 80% of what all the providers charge for a specific service in a given area of the state. So there was a study that was conducted by the University of Alaska, the ISER, which is the Institute of Social and Economic Research, and it was just completed about a month ago. It found that the rule contributed to anywhere from 8% to nearly 25% of the annual growth in spending. The headline in the newspaper after the report was laid down attributed $85 million to states' spending, healthcare spending, directly attributable to this 80th percentile rule, which of course gets everyone's attention. They said about 22.5% could be attributed to the rule. One of the complicating factors that we have in the state, and Senator Enzi mentioned it as well, as a rural state, you have few specialists, so you essentially have a few number of providers that are effectively setting the rate for the entire state. The Division of Insurance is looking at this, considering whether or not making changes are appropriate, possibly even eliminating it entirely. I bring this up because it is something that is unique, I understand, to Alaska, but it was also designed to deal with what Senator Enzi has raised, what other rural states deal with lack of specialists. So I would like your comments, if you are able, but also recognizing that we've got a situation where we don't want to leave our emergency providers basically holding the bag if your folks are brought into the emergency room because you're in an out-of-network situation. So again, I apologize for the very parochial nature of this, but again, when you're looking at something that we've experimented a little bit with to see if we can't reduce our costs, and now we're finding that we've gone the other way. Can any of you comment? Dr. Bunton and Dr. Ya, both of you are nodding your head like, okay, let's think about this. Can you help me out, because we're looking for some advice here.
Well, it does sound like the unfortunate law of unintended consequences, which comes into policymaking so often. This is an issue that was brought up in the opening remarks by both Senator Murray and Senator Alexander. What do people do about out-of-network providers and these surprise bills? So this is a seemingly logical step to take to say we're going to limit those out-of-network prices to 88%. The situation in Alaska is that the population distribution is so sparse, there's so few providers, that it just might make economic sense for a provider to just take the 80% of whatever the highest rate is available in the state. So maybe that worked at first, but now it's a situation where the insurers are having difficulty getting the providers to the table to negotiate rates that are lower. It might be the type of situation where it's good to seek external reference prices.
External
external prices to reference. So external perhaps to the state or perhaps Medicare prices. This was an idea that Senator Cassidy brought up. I don't remember if you were in the room at the time. So those are possible solutions. I'm certainly not an expert in this area, and perhaps Dr. Jha is going to comment on it, but there are 20 some odd states that have been facing this problem and trying to look for other solutions, and it's possible that some of us could look into that and get back to you about whether any of them have come up with solutions that might work given your unique circumstances in Alaska.
Thank you. Dr. Jha?
Let me just add that there are a couple of problems that are contributing to this, and one of them is we've talked about the importance of competition. Well, you've highlighted, Senator Enzi highlighted. It sounds great on paper, and in lots of places it works, but in large parts of Alaska, it's going to be a challenge, and that, of course, makes sense. But actually, we heard earlier that there are some things that we can do to try to improve access and can actually help with competition a little bit, such focus on telemedicine. I actually think Alaska has been doing a lot in this area, but we could do more still. Medicare, I think, is something can push this a bit more than it has in terms of how it pays for these things. So there are policies that we can put in to try to create a little bit of virtual competition where real competition is hard, but that doesn't get away from the problem that you have highlighted. And it's very interesting because when you first described the 80th percentile rule, my first thought was, well, that seems pretty reasonable. And then as you describe the impact of that, I realized, but in this case, it won't work. And so what other states have done is have said things like, if you go out of network, you're getting a certain percentage of Medicare. So you might get 110% of Medicare as your payment. And that changes the incentive because you're no longer referencing to the highest price guy in your community. Now you've got a national number to deal with. And that is more likely to bring providers into the conversation with insurers to be in network. So that's what I believe about 6 states have done in terms of this. I'm happy to work with your staff to get you more detailed information. But this is a complicated problem, but I think we can make progress in this area.
I appreciate that, and I would like to follow up with you. Let me ask one more quick question, if I may, Mr. Chairman, and I will be very brief. But the administrative burden that you have raised, Dr. Jha, clearly, I think, a reason for some of the higher prices. Others say that consolidation drives the prices. But I've heard from several of our hospitals and doctor groups that it's the administrative burden that is driving the consolidation. In some of our smaller communities, it just doesn't work. Small practices just can't afford to bring on the folks to deal with the billing, to deal with the insurance companies, to deal with Medicare, Medicaid. They can't deal with it. And so they've got to find their efficiencies of scale. So would reducing the administrative burden also reduce the trend of the consolidation that you have suggested and effectively work to protect patients from rising costs?
So the evidence on this is that the average physician has somebody working in his or her office about 15 hours a week just to do reporting on quality data, et cetera. So if you think about a 3-physician practice, you're hiring close to 2 full-time people, or a 1.5 full-time people just to manage all this administrative requirements. That's not even your own administrative time. And what happens more and more is hospitals show up and say, we'll buy out your practice, we'll do all of that for you, and you just practice medicine. Sounds pretty good. And so I do think that these 2 trends that I actually kept separate in my own testimony, I think you've done a very important job of linking the 2 and reminding us that these are not separate phenomena, and one may actually be feeding into the other. And we have to look much more sharply, much more closely at the administrative challenges that physicians face, because it does make them much more susceptible to just giving up that part of their practice, becoming an employee. And consumers are not necessarily helped by that.
Do you have any answers to that yet?
Well, so I think we have to look at, so if the quality measures, for instance, if you're employing somebody 15 hours a week on average, we've got to get to electronic quality measurement. I mean, the idea that you hire a nurse to go through your chart and document stuff and file it, we're in 2018. Like, we should be able to do this electronically. So we've got to push the electronic health record stuff to make this stuff much more streamlined and much more efficient. So I think that's one place where we can make some progress.
Senator, I would just add, first of all, the perhaps apocryphal story is that Duke University Hospital has 1.5 billing clerks for every bed that it has. So one of my friends checked in and said, where's my 1.5 billing clerks?
Wow.
But the caution I would add is unless the market is competitive, even if you succeed in lowering administrative overhead, it doesn't follow that prices will drop, right? So you need to attend to both of those things. And I don't think competition's been highlighted repeatedly, but it's important to recognize even if we cut administrative overhead in half, providers could pocket that unless they were competing with one another.
And I think specific to the issue of the acquisition of physician practices by hospitals and hospital systems, that can actually have an inflationary effect on spending because of something that was, one price in a physician's office is now a higher price because it's being covered through a different hospital payment system.
Mr. Chairman, thank you. You have been very, very generous, and I thank the panel for your help. I look forward to following up with you, but thank you, Mr. Chairman, for holding this over.
Thank
So
you,
appreciate it.
Senator Murkowski.